Okay, let's talk about cataracts. So, what is a cataract? It is a lens opacity that distorts the image. As people age, the lens gradually lose water and increase density. Lens density increases with drying and compression of older lens fibers and the production of new fibers and lens crystals. Both eyes may have cataracts, but the rate of progression is different in each eye. So, what are we going to do with these patients? That's what a cataract is. So we want to ask their history, okay? Or do they have a recent or past trauma to the eye, exposure to radioactive materials like x-rays or UV light, prolonged use of corticosteroids, beta blockers? Do they have a presence of intraocular disease? Do they have presence of systemic disease like diabetes, hypoparathyroidism, hypertension? Have they had previous cataract or family history of cataracts? Do they have a history of smoking? And then early signs and symptoms of cataracts are slightly blurred vision and decreased color perception. That his or her glasses are in at first, the patient may think his or her glasses are smudged or contacts are not fitting correctly. As lens cloudiness continues, blurred and or double vision occurs, and the patient may have difficulty with ADLs. Patients commonly report increasing difficulty seeing at night, especially while driving. Without surgical intervention, visual impairment progresses to blindness. No pain or eye redness is associated with age-related cataract formation. Now, unless a cataract has matured, it is not always visible to the naked eye. Visual sensory perception is tested using an eye chart and brightness acuity testing. The healthcare provider will examine the lens with an ophthalmoscope and note any observed densities by shape, size, and location. A slit lamp can also be used to visualize the cornea, iris, and lens. As a cataract matures, the opacity makes it difficult to see the retina, and the red reflex may be absent. When this occurs, the pupil is bluish white. So as long as a patient does not have cognitive deficiency, he or she is expected to recognize when ADLs cannot be performed safely and independently due to cataracts. For patients on Medicare, coverage is provided for the implanted lens during cataract surgery. The cost of the facility, provider, and supplies needed to perform the surgery. And one pair of glasses or contact lenses after surgery is provided. So surgery is the only treatment to treat cataracts and should be performed as soon as possible after vision is reduced and ADLs are effective. So what are we going to do on pre-op day? The eye care provider provides information about the procedure so that the patient can make informed decisions about treatment and then options obtained. Hold on. So let's start over. So the eye care provider provides information about the procedure so that the patient can make informed decisions about treatment and then obtains informed consent. Now, we are to teach that care before and after surgery requires regular self-examination of the eye and installation of different types of eye drops several times a day for 2 to 4 weeks. In very rare cases, the doctor will not prescribe eye drops before surgery, but we have to advise the patient to clarify with the eye doctor whether there is a need or lack of need to use them before the procedure. If the patient is unable to instill drops, help him or her make arrangements for this care. Ask her whether the patient takes any drugs that affect blood clotting, such as aspirin, warfarin, those type of drugs. Communicate this information with the surgeon because for some patients, these drugs may need to be discontinued before cataract surgery. A series of drops are instilled just before surgery to dilate the pupils and cause vasoconstriction. Other eye drops are instilled to induce paralysis to prevent lens movement. When the patient is in the surgical area, a local anesthetic is injected into the muscle cone behind the eye for anesthesia and eye paralysis. Now, post-op care. Post-op care immediately after surgery, antibiotic and steroid ointments are instilled. The patient is usually discharged within an hour after surgery after stabilization and monitoring. Instruct him or her to wear dark glasses outdoors or in brightly lit environments until the pupil responds to light. Teach the patient and family members how to install the prescribed eye drop. Help them to create a written schedule for the timing and the order of eye drops administration. Remind the patient that vision in that eye will be blurred and not to drive or operate heavy machinery until the ointment is removed. Stress the importance of keeping up all follow-up appointments. Remind the patient that mild eye itching is normal, as is a bloodshot appearance. The eyelid may be slightly swollen, however, significant swelling or bruising is abnormal. Cool compresses may be beneficial. Discomfort at the site is controlled with Tylenol. Pain early in the surgery may indicate increased intraocular pressure or hemorrhage. Instruct the patient to contact the surgeon if pain occurs with nausea or vomiting. To prevent increases in intraocular pressure, teach the family and patient about activity restrictions, and that is they cannot bend from the waist, they cannot lift objects weighing more than 10 pounds, don't sneeze or cough, don't blow the nose, no straining to have a bowel movement. You want to teach them not to vomit, not to have sexual intercourse. They have to keep their head in a dependent position, and they don't need to wear tight shirt collars. Infection is a potential and serious complication. Teach the patient and family to observe for increasing eye redness, a decrease in vision, or an increase in tears and photophobia. Creamy, white, dry, crusty drainage on the eyelid and lashes is normal. However, yellow or green drainage indicates infection and must be reported. Stress the importance of proper hand washing to reduce the potential for infection. Patients usually experience a dramatic improvement within a day of improvement in vision within a day of surgery. Remind them that the final best vision will not occur until 4 to 6 weeks after surgery. Now, because the patient is usually discharged within an hour after cataract surgery, nursing interventions focus on helping the patient and family plan eye drop schedule and daily home eye examination. Now, if the patient has difficulty instilling eye drops, a supportive neighbor, friend, or family member can be taught the procedure. Adaptive equipment that positions the bottles of eye drops directly over the eye can also be purchased. To achieve best results of cataract removal, the patient must be taught to closely adhere to the eye drop regimen after surgery. Providing the patient and family with accurate information and demonstration of needed skills are nursing priorities. Before discharge, review these complications with the patient and family. Although complications are not anticipated, teach the patient to immediately report any of these symptoms following cataract surgery. If they have sharp, sudden pain in the eye, bleeding or increased discharge from the eye, green or yellow thick drainage from the eye, eyelid swelling of the eye, reappearance of a bloodshot sclera after the initial appearance has cleared, decreased vision in the eye that had surgery. Flashes of light or floating sharp shapes seen in the eye. Remind the patient to avoid activities that increase intraocular pressure. Some patients are prescribed to wear a light eye patch at night to prevent accidental rubbing. Instruct the patient to avoid getting water in the eye for 3 to 7 days after surgery. Teach the patient about activity restrictions. Cooking and light housekeeping are permitted, but vacuuming should be avoided for several weeks because of the forward flexion involved and the rapid jerky movements required. Advise the patient to refrain from driving until vision is clear. Again, the patient after cataract surgery. We want to assess the visual acuity in both eyes using a handheld eye chart, visual fields of both eyes, presence of absence or redness, tearing, and or draining in the operative eye in comparison with a non-operative eye. You want to ask the patient if there is pain in or around the operative eye, if there has been any changes in the vision in the operative eye, whether these have been noticed in the operative eye, are they having dark spots, increase in the number of floaters, are they seeing bright flashes of light? You want to assess the home environment for safety hazards, especially tripping and falling hazards, and assess the level of room lighting. You assess a patient to adherence to and understanding of treatment and limitations such as signs and symptoms to report, the drug regimen, activity restrictions, and are they the ability to perform